Okay, so let me stand here so that I can look at both the audience and my slides. So Karen, thank you very much for the kind introduction. And what I would like to do in the next 20 minutes is to share with you some of our findings on the dexamethasone's effect in patients who received the NovoTTF device. And I too received a grant from NovoCure for some of the clinical studies and also for some of the translational studies. And I must say that it is invigorating. On Sunday afternoons when I have a cup of coffee with Ken and we chatted about the mechanism of how this works and how this translates into clinical medicine, and we share our thoughts every weekend. And it's from this exchange that we come up with things that I analyze clinically, as well as things that we need to analyze on the bench. So Ken spoke to you about these cells that are blowing up, and it took about 10 years into translating into this FDA-approved device in which patients wear these two pairs of transducer arrays that are arranged orthogonally, and patients wear a electric generator and also a battery pack. Now, I think the key point, and I would like to emphasize this, is that the electric field exerts a force on the charge, whether or not the charge is a pure charge or a dipole. And that force can be translational, it can be rotational, or a combination of translational and rotational fashion when the field is inhomogeneous. If you don't believe me, you can take your children or your grandchildren to your local children's museum, put your hands on the Van de Graaff generator, your hair will stand up because the field levitate your hair against gravity. Now, another thing that I learned when I was an undergraduate student at Penn in the electrical engineering curriculum was that how well an electric field penetrates a medium really depends on its frequency. And I had to go through that painful exercise of vector calculus in order to see that. And it was great when I first encountered this device because one of my first questions was, does it penetrate from the surface of the scalp into the brain? Okay, and it did based on this paper. And permittivity, which is a measure of how well the electric field permeates a medium, is essentially the same for bone, gray matter, and white matter at the frequency that the NovoTTF device operates at. So that means this is similar to light coming through the window into this room. You can read a book outside and you can read a book inside. It's the same light, okay, at that frequency. So based on the first phase 1 study with about 10 patients, the company initially obtained very favorable response rate and long-term survival. But when it came into a phase 3 clinical trial, the efficacy results was rather a little bit disappointing because when compared to traditional cytotoxic chemotherapy, it was essentially the same. The median overall survival was 6.6 months versus 6 months. 1 year survival was 20% in both groups. The median progression-free survival, meaning that the patients live without tumor progression, is essentially similar, 2.2 months versus 2.1 months, and the progression-free survival at 6 months, right about here, is about 21% versus 15%. So it's one thing for a clinical investigator to say, okay, well, that's the clinical trial result. It may work or it doesn't work, but it is very important for the clinical investigators if the results deviates from your expectation, from your hypothesis, we have to figure out why. Okay, so one of my job was to find out why in this phase 3 trial the efficacy results was less than robust, and that came from a lot of discussion and looking at the data that Ken Swanson generated in the laboratory. So the first thing that we did was look at the responders. Okay, why did the responders respond? And two things came out. One of the things was that, and we did this in a post-hoc fashion. Given the fact that it's post-hoc, one can debate how valid this is. However, it requires a prospective validation. So one of the things that we found was that the responders had secondary glioblastoma more frequently than those with previous those with secondary glioblastomas. They lived longer, and they also had like longer progression-free survival. Now, there were 14 responders in the NovoTTF group, and there were only 7 responders in the chemotherapy group. And none of the 7 responders in the chemotherapy group had prior low-grade tumor, suggesting that for the electric field therapy, the genetic background of the tumor may make a difference. However, we don't know what that is yet. Another thing that fell out from our analysis was responding patients, whether or not you are in the NovoTTF group or the chemotherapy group, they utilize much smaller doses of dexamethasone, either on a daily basis or in a cumulative basis. And the median dose is about 1 to 2 milligrams versus 6 to 7 milligrams in the non-responders. And that's about the time when the immunogenic cell death data came out. So we decided to go back and analyze the entire group and ask the question, how extensive is the effect of the dexamethasone on both cohorts? And when we reviewed the literature, actually Skip Grossman and Lawrence Kleinberg from Hopkins actually published a number of papers from Johns Hopkins looking at the infections risk and the survival rate based on looking at low CD4 count in patients who receive radiation. Now, this paper was published in 2005, and at that time, newly diagnosed patients with glioblastoma only receive involved field radiation. And what they found was that among this 70 patients, what they found was that the steroid dose was basically equivalent. However, when patients' CD4 count dropped below 200, their hospitalization rate and the hospitalization with respect to having a major infection really goes up substantially. Now, I just want you to pay attention is that this CD4 count is irrespective of the mean white blood cell count. So in all 3 groups, in these 2 groups, CD4 less than 200 and CD4 greater than 200, the mean white blood cell count is essentially the same at about 7. Also, the steroid dose is pretty much the same, about 23, 24, but that's a little bit high from my standpoint. In my institution, we don't use that high of a dose of dexamethasone to treat patients during the radiation. So as you can see here, when patients are on steroid during the radiation, their CD4 count kind of drops over time. And when it drops below 200, that's essentially similar to AIDS patients because AIDS patients typically would have various types of infections when their CD4 count drops below 200. They follow up with a more recent paper that was published in 2011 in the Temozolomide plus radiation era, and they found the same thing. That patients with CD4 count less than 200, they have a poorer survival than those who have a CD4 count of greater than 200. So, with this background, we went back in. We spoke to the sponsor, and we got all the raw data in, and a student at Log and I, as well as with Ken Swanson, analyzed the dexamethasone effect. And we use an unbiased fashion. The student wrote a computer program in which he picked out in a systematic fashion at each dexamethasone dose, he separate out the cohort in the TT fields and as well as in the chemotherapy group into 2 cohorts and compare the survival, the median survival, and we asked the question at what dexamethasone dose would give us the biggest survival difference. And that dexamethasone dose was at 4.1 milligrams a day. So in the TTFields group, we dichotomized this cohort into two groups, less than or equals to 4.1 milligrams per day, and those who took dexamethasone more than 4 milligrams a day. And the survival difference was almost 3 times as much in the former group, 11 months versus 4.8 months. So the lower dexamethasone group is in this solid line, and the higher dexamethasone group is in this dotted line. So we apply the same cutoff for the chemotherapy group, and we see the same thing, although the separation is not as robust as the previous group. So the solid red line is the group in the chemotherapy cohort taking less than or equals to 4.1 milligrams a day, and the dotted line is the group that takes more than 4 milligrams a day. Then our question is whether or not those who are taking a smaller dose of dexamethasone has smaller size tumor, because we use dexamethasone to treat brain-induced edema. And the answer is yes, there's a little bit of smaller tumor size, but this did not turn out to be statistically significant, suggesting that it's not a tumor size that caused the difference in survival. It's something else. Then we did this plot in order to look at the various distribution of dexamethasone's effect on overall survival. And this is how it goes. We basically start at 1 milligrams of dexamethasone, split it into 2 groups, and say what are the survival differences, and then plot it on a graph. Okay, so this is dexamethasone dose. This is overall survival, and at each split point, we create a point, and then use curve fitting, we generate a curve. And what we observed was that there's an inflection point. The inflection point is at about 8 milligrams a day. And there's also a plateau, and the plateau is about 4 milligrams a day, or 4.1 milligrams a day, suggesting that there are 2 points that are important for us to look at. Now, we know that this inflection point was familiar to me because there was a paper that was published on the infection side effects from dexamethasone, and patients who took 8 milligrams or less of dexamethasone have far fewer side effects than those who are taking more than 8 milligrams a day. So this inflection point could be a reflection of the infectious complications. And likewise, when we apply the same algorithm to the chemotherapy-treated cohort, we see pretty much the same thing. The inflection point was at 7.5 milligrams per day, and the plateauing occurs at about 3 milligrams a day. Then we combine the blue line, solid blue line, with the solid red line, okay, because these patients are from the same clinical trial. They're comparable, so we basically, within this clinical trial, did 2 comparisons. In comparing those patients who took less than 4 milligrams a day of dexamethasone, compare TTField treatment with chemotherapy treatment. And this is what we found. The curve on initial inspection looked pretty much overlapping, and likewise, with those patients who took more than 4.1 milligrams per day, we compare TTField treatments versus chemotherapy. The curve looked overlapping. However, if you look closely, and this was pointed out by Ken Swanson, is that there seems to be a slight separation initially in this curve, and there is a slight separation in this bottom half of the curve. So we basically looked at patients in the top half of the curve and asked the question, is there a survival difference when we look at this top half of the population, and there was a survival difference. When patients had when patients took less than 4 milligrams of dexamethasone per day, TT fields confers a survival difference when compared to chemotherapy. On the other hand, when patients took more than 4.1 milligrams a day, in this bottom half of the curve, TT fields did not have a survival advantage, and in fact, their survival was worse, suggesting that the dexamethasone may counteract the efficacy of TT field. So we tried to validate this finding, and fortunately, because the device was approved and we are using it for the general population of recurrent glioblastoma patients, we accumulated a sizable cohort, about 35 patients in our institution, and we analyzed this as a validation cohort. We tried to validate what we saw in the EF11 and see whether or not we saw the same thing. And within this cohort, the median Karnofsky score was about 70. We had no restrictions in terms of who can get the device and who did not get the device. The tumor size may be a little bit smaller. The dexamethasone dose, the median is about 3 milligrams, and because of the immunological aspects, we have been getting T-cell subsets in our population. And within this T-cell subset, we had CD3, CD4, and CD8 counts. And the number of prior therapies, some had, most of the patients were in this first or second recurrences, but in the third recurrence, fourth recurrence, or even fifth recurrence, patients were eligible, and about more than half of the patients had prior bevacizumab use. And the overall survival was pretty similar to the EF11 trial, about 5.4 months, whereas in the EF11 trial, it was about 6 months. So we started analyzing our validation cohort, and what we found was that patients who had Karnofsky score of greater than 70, they clearly did not do as well as those, they clearly did better than those who had Karnofsky score of less than 70. And then we kind of overlapped the patients who had the, and then we compare, and then we split this green curve, patients with a Karnofsky score of greater than 70, into those who were taking less than 4.1 milligrams of dexamethasone versus those who were taking more than 4.1 milligram of dexamethasone, and clearly there was a difference. The median survival was 8 months versus about 3 months, and we tried to overlap our validation cohort with the EF11 cohort, and they look pretty similar. About 9 months versus 11 months, 3 months versus 4 months, 3 months versus 5 months here, suggesting that what we saw in the EF11 can be validated with our own patient population. Then we went into the analysis of the immune cell profile, and we used the same algorithm to look at whether or not there's a survival difference with a CD3 cutoff or CD4 cutoff or CD8 cutoff. Because we have data for comparison for CD4, our cutoff was at about 236, okay? So that's similar to what the Johns Hopkins data said with their cutoff of about 200 cells per cubic millimeter. We then next look at whether or not there's a correlation with dexamethasone in terms of the number of immune cells, and yes, there's a negative correlation with the T-cell subsets with respect to the doses of the dexamethasone. The higher the dose, the lower the T-cell subsets. And we also looked at whether or not there's any internal correlation between CD4, CD8, and CD3. And CD3 is just a general marker for CD4 and CD8, and we see that there's strong correlation. However, there's no correlation between CD4 and CD8 cells, suggesting that these are two separate populations of cells. And like the Johns Hopkins paper, there was no correlation between the number of CD3, CD4, and CD8 with the total number of white blood cells in these patients, suggesting that these are independent markers of immune function. Now, then we looked into the literature a little bit deeper, and guess what? The scientists, the clinician scientists who did the most work on steroid and T-cell function is Anthony Fauci, and I first heard of him when he was doing his HIV work, and now he's doing Ebola work. And prior to his HIV work, he was working on the steroid's effect on the immune system. And this is what he found. In normal volunteers, steroid, no matter what kind of steroid you use, hydrocortisone, prednisone, or dexamethasone, the number of lymphocytes will drop within 4 hours, and it will recover by 24 hours. It's pretty much similar for all three drugs. Okay. However, there's a qualitative difference. So there's no quantitative difference, but there's qualitative difference. So what happened is that the top panel is with hydrocortisone. And on the x-axis is phytohemagglutinin that he used at various doses to stimulate the T cells. And as you know, when you add phytohemagglutinin, the T cells will undergo mitosis and expand. So, and this is all done between 0 and 4 hours. And what he found was that he could overcome the drop in lymphocyte count by increasing the dose of phytohemagglutinin to counteract the effect of hydrocortisone, to counteract the effect of prednisone, but not for dexamethasone. In other words, dexamethasone is a really, really lymphotoxic, not only on a quantitative standpoint, but on a qualitative standpoint on the subject's immune function. So this is my conclusion. Dexamethasone may interfere with the treatment of glioblastoma in the EF11 trial, and this perhaps is the reason why we did not see a survival difference. TTField treated patients who used dexamethasone less than 4.1 milligrams a day had a longer overall survival than those used more than 4 milligrams a day, 11 months versus 4.8 months. Dexamethasone at more than 4 milligrams a day appears to counteract the efficacy of the electric field therapy as if these patients did not get any treatment. And in our combinatorial analysis, which I did not have time to go over, the best patient profile are those who had a CD8 count of greater than 144 cells per meter square, a CD4 to CD8 ratio of less than 1.1, because CD8 is actually the immune effector cell that helps, that we believe helps to fight off the tumor, and the dexamethasone dose less than 1 milligram a day. That confers the best overall survival in our validation cohort. Thank you very much.
Would you mind using the microphone?
So Eric, great talk. Almost got me convinced. The one thing I didn't see in your analysis was we know there's a very big treatment bias on patients who are using the NovoCure fields. So what was the time difference? Because certainly those taking large doses of dexamethasone may not be wearing their device quite as much. Did you break it down that way as well?
No, I didn't. Patient utilization could be an issue. I did not go into analyzing the compliance percentage. I think that is a good point. I analyze the compliance issue. But as I said before, this requires a prospective validation of this phenomenon. And I hope that when the EF14 trial is done, because I suspect that those patients may utilize a smaller dose of dexamethasone because they don't have an active tumor that the neuro-oncologists or neurosurgeons have to manage their potential side effects. I hope to analyze that cohort of patients and get another prospective validation as well.
Dr. Wong, thank you so much for your talk. It's always good to listen to your mentor talk, but I have a question on your presentation. I know you gave a very good talk on dexamethasone dose and the effects on TT fields. Have you looked at Avastin? Because I know Avastin, even though it does not prolong overall survival in patients with GBM, it can also play a role as a steroid. Have you done any studies to look at the effects of Avastin on TT fields?
Well, in our validation cohort, we had no restriction on Avastin use. And in fact, in order to get, in my clinical practice, in order for me to get the steroid dose down, I utilize Avastin in terms of controlling cerebral edema very aggressively. But still, in our validation cohort, there is a range of steroid doses that even with Avastin or bevacizumab, patients still require some steroid in order to manage their symptoms. Now, I want to add this point parenthetically that Avastin is not just an anti-edema drug. And it is becoming clear, and if you can read this month's editorial from George Sledge in the Journal of Clinical Oncology, he will talk about Avastin, bevacizumab failed breast cancer miserably, whether or not you are attacking the VEGF at the ligand level, receptor level, or whatever level, okay? However, there is an immunological effect on the tumor microenvironment. When you take away VEGF, you are taking away the chemotactic factor for myeloid-derived immunosuppressive cells. You are taking away the Tregs. So there's a lot of remodeling immunologically from bevacizumab within the tumor microenvironment.
Soren Single, great talk. Do you mean to say that in order to manage them clinically a little better, without dexamethasone, you tended to put them on Avastin more frequently?
Yes. Yes.
So is that maybe influencing your data then on the better outcomes slightly in that one?
I don't think Avastin influence the overall survival of this population of patients. Okay. Now, it hasn't been definitively demonstrated in the recurrent setting, okay, so I can't say, but in the upfront setting, I mean, there's no overall survival advantage.
Okay.
Another drug that I use, as Dr. Swanson alluded to, is Celebrex, Celebrex, COX-2 inhibitor. We use that dose very liberally because not only does it have a little bit of anti-edema effect, it also blocks COX-2 and it helps the immune system of that particular patient.
Great. So are you planning then to do a study also to do no TTF, just GBMs with Celebrex and Avastin versus standard treatment with dexamethasone then, or just to clean up those effects?
Sure, I think proposing such a study is easy. Getting funding is so it all boils down to funding. Okay, can we get funding for such a study?
No, but it's exciting.
No, I'm just saying. But you know, I think in order to do such a trial, we have to do it intelligently and maybe tack onto another drug or having this as a control arm in another trial, because I think NIH has no money, and I don't think any private sponsor would want to fund this.
Thank you.
Yeah. Thanks.